Good morning, everyone. Welcome. Welcome to the 16th lecture in our Healthy Aging series. My name is Shannon Echeverry. I'm the Director of Silver Club Memory Programs, and I will be moderating today's lecture. First, I would like to thank the Planning Committee and everybody that was involved in making this possible, including all of our programs, which are the U of M Geriatrics Department, the Turner Senior Wellness Program, the Osher Lifelong Learning Institute, Silver Club Memory Programs, the Turner African American Services Council, the Institute of Healthcare Policy and Innovation, and the National Poll on Healthy Aging. Today's topic is caring for a loved one with dementia. We have Les Dubin and James Manji joining us today. I'll introduce them and give you a little bit more detail in just a couple minutes. So first, I wanted to start out with some logistics and technical pointers here. So we are using Zoom today. So the important things to know would be that your way of communicating with us is through the Q&A icon. So throughout the presentation, please feel free to submit your questions for Les and Jim, and I will answer those questions at the end of our session today. There is a chat icon, but you don't need to use it. Please just use the Q&A. That's the easiest way for us to field questions. We do have a closed caption option if you would like to use that. If you look at your screen, you will see a CC in the meeting controls that you can click on, and you can use the closed caption or live transcript if you would like to do that. If you are having any technical difficulties with today's presentation, if your screen freezes up, or if you have any other issues, you can call the Turner Senior Wellness Program at 734-998-9353. Also, would love to let you know about our next presentation, which is going to be Friday, May 3rd at 10 a.m. It's going to be Coping and Resilience During the COVID-19 Pandemic, Voices from Aging Adults in the Nationwide COVID-19 Coping Study. So please mark your calendars for that. And now our legal disclaimer: the views expressed during this lecture and the Q&A do not necessarily reflect those of the University of Michigan. So today we have an hour-and-a-half presentation followed by 30 minutes Q&A. Remember to use the Q&A icon if you have any questions. So with all that aside, I would like to introduce our speakers. Leslie Dubin is a clinical social worker who has worked in health systems for over 25 years. She specializes in working with older adults, particularly those impacted by cognitive disorders. She currently works on the geriatric inpatient consultation team at Michigan Medicine. She is also an adjunct lecturer at the University of Michigan School of Social Work and has spoken at conferences nationally and abroad on aging issues. Welcome, Les. Jim's first career as a federal government consultant and owner of an In No Way prepared him for his second career as a caregiver for the past 14 years on her unwelcome journey with dementia. Her Alzheimer's disease has changed Jim too. No longer a clueless caregiver, Jim is now a better informed caregiver for his wife and an advocate for better support for other caregivers wherever they are on their journey. So everybody, welcome. I hope you enjoy this presentation. And we are going to start off with Les.
Good morning, everyone. Can you hear me?
Yes.
Okay, great. Thank you. Okay, I'm going to go ahead and share my screen. So give me just one moment while I get this set up. Appreciate your patience while I sort through the technology here. Let's see. Let's see. Just have to get to the, oops. Start this program button. The box is in the way, so forgive me one moment. I apologize. I want to thank you while I'm figuring this out. Oh, I don't want to leave the webinar. There we go. Start slideshow. Oh no, Jen, I might need your help starting this slideshow.
So Les, you should be able to click on slideshow on the bar on the top of the screen.
Yeah, so the black Zoom link is blocking the button to do that.
You should be able to move that. There may be a down arrow that you can click that'll move that bar to the bottom of your screen.
There we go. Thank you.
You're welcome.
Got it. Okay, so now you should be able to see the slide, correct? Okay.
Yes, we can.
All right, wonderful. Well, thank you again for your patience in that. And I really want to thank the program for inviting me to have an opportunity to present along with Jim some of the experiences of working with caregivers. What's happening? So my slide, there we go. So I'm not going to go through my entire history because Shannon did that, but I think what I want folks to know is that I'm coming from about 25 years experience. The last 14 of those years have been here at Michigan Medicine, working with families, mostly in the hospital setting, although I do have contact with folks who leave occasionally and also have a very small counseling practice outside. But what this has provided me, and I'm very appreciative and grateful for all the families and the persons living with dementia that I've had the pleasure of working with through the years. I've counted, trying to figure out exactly how many people I've worked with, and somewhere between 800 and 1,200 a year. So thousands of people I've really enjoyed getting to know and being on their journey with them. So what I'm going to come from is a perspective from a healthcare side and kind of what I see at different processes, at different places where folks are in their journey. Regardless of your politics, I really, really love this quote. There are only 4 kinds of people in the world: those who have been caregivers, those who are caregivers, those who will be caregivers, and those who will need caregivers. And for me, I really have the opportunity to work with all generations of people when I'm working with families. And so I can see, and I've really had the opportunity to talk with different people as young, as 3 and 4-year-old grandchildren who don't understand why a certain family member is acting a certain way, to spouses who have been married 80 years or more. So I really feel like this quote captures where we all are and really sort of highlights that this is a family condition, but that how also each of us in our own personal journey in life, that we ourselves may need that help, but that we might find that we are the ones needing to provide that in some capacity. So before we get into that, I'm going to interchange some words here. I'm sometimes going to use the word caregivers, but I'm also going to use the word care partners. And I think what we in meeting with, again, all of the people involved in the process of living with cognitive disorder, is we are hearing sometimes from folks that the person living with the disease is struggling with feeling like a burden. And when they feel that they need care from someone else, that can sometimes cause certain amount of guilt or frustration or sadness. And so language might be something to be considered of, especially in those very early stages where persons living in the same household or providing care do feel that they are a caregiver, but that we really want to reframe that a bit in terms of the language and how that can be perceived, to think more about partnering. On the other hand, I had an example of a couple that had been together for quite some time, and the wife did not feel that caregiver was the right term. And she was one of the people I had a very good in-depth conversation with about the terminology of how we phrase what our role is, and how the person that we're partnering alongside with, how they feel about those terms. So I just want to bring this to your attention when you think about this, especially when your loved one is with you, that you think about the language and how they might perceive that. And I think the care partner is also appropriate because dementia is a family disease. You are partners, as you have been through so many other examples in your life together, but you're each experiencing a different part of your relationship. You're each experiencing different decisions that you need to make differently, and you might both need to make different decisions for your own situation, but also being mindful of what your loved one is going through. So I just wanted to point out why I will be using different terms throughout the presentation today. This slide is very busy, and I don't expect you to read it all, but you will get copies of these slides. This is from the AARP website, and the link is going to be in the back for the whole presentation. If you want more information about any of these slides, you'll be able to access those. But the part here that I highlighted is that 23% of Americans say that caregiving has made their health worse. And this is more general as far as caregiving in any capacity. So this could be a loved one that's maybe struggling with some sort of cancer or just following a heart attack. But we can see that a lot of people provide care in some capacity. In 2020, 53 million Americans are helping a loved one in some way and identify as a care partner. But 23% of them, so if you take 23% of 53 million people, identify that their health has been impacted. And this is why we want to pay so much attention to providing care partners with information and reminding them they are not alone, even though it feels very isolating to be in this role often. But that it's important for them to figure out the balance of how to also manage their own needs. When we look at dementia-specific caregiving, in 2019, more than 16 million family members and friends provided 18.6 billion hours of unpaid care for people living with Alzheimer's or other types of dementias. And so this is, again, I'm not going to go through a ton of academic information during the course of this presentation, but if you hear that, I hope that one of the points you take from that is that you really are not alone. And as I mentioned, people feel very isolated and alone, and they're not sure who they can talk to. But the reality is that about 5.8 million people in the United States have an Alzheimer's disease or related dementia. The problem is, as a society, we haven't talked about it very much. There's a lot of stigma. There's embarrassment for the folks who have the diagnosis. We're worried about how the people we're living with are going to cope with that information. Are they going to treat us differently? So I think it's really important for all of us who are impacted by this in some way is to recognize the magnitude of just how prevalent this is. And we know with the baby boomers continuing to prosper, and we manage so many other health issues well, that the probability that more and more people are going to be diagnosed with a cognitive disorder is extremely high. So this slide, I hope, provides a little bit of information to folks who do feel isolated, that this is a problem that is not only more prevalent than we know, but that it is a burden that a lot of other people share, and that together we have to continue to talk and help each other through what some of these options are. The last point in this particular slide is that these folks who are caring for others often are adult children who have younger persons that they're also managing, that sandwich generation we talk about, but also older adults who are managing their own health issues. And I'm going to talk about that later, because as we talk about that 23% of folks who identify their health is deteriorating in some way, we have to talk about why it's important to try to get our arms around that and take care of ourselves if we're going to try to help partner with someone else in their care. This slide, I've already mentioned that dementia is a family disease and it impacts people over time. The reason I wanted to highlight this in conjunction with the previous slide is that we talk about the burden that people feel, the sandwich generation. And I think a lot of care providers who are spouses in particular, my experience is that they really want to protect their children. They don't want to be a burden to the family, that they feel like they have managed this far. You know, we've always taken care of ourselves. And so, you know, my daughter has to get her daughter to soccer games or what have you. I think what I hear from adult children is many of them want to be more involved, that they wish their parents would include them more in their options, but they don't always know what to do. And so I want to just highlight this for you to think about if you find yourself in the situation. Your children are concerned if you're a parent. Your grandchildren are wondering what's going on, why are grandma or grandpa acting differently? And I think that we need to really recognize that there's real value in providing education and accessing support groups so that people can feel included and to try to figure out how they can help each other, because everyone is impacted, some more than others for sure. But think about how within your own family, your own network, your own community, how you might be able to access the whole wealth of opportunities that might be there, and not avoid that because you're worried about burdening somebody. The other thing that I hear a lot of care partners struggle with is doing everything the right way, making sure they're getting everything they can to tackle this and manage a cognitive disorder diagnosis as well as they can. And that's a great plan. We should all be trying to figure out how we can manage any condition that we have, whether that's a cancer, heart disease, obesity, depression, whatever that is. We should try to get information. We have the internet at our hands that can be a blessing and a curse, but there are and is value in trying to figure out ways to maximize opportunities. However, every situation is unique. I love working with older adults because of the variety of life experience that they bring. I am a talker, I'm a social worker. I love to hear stories. I love to hear how things have changed over years, how you did things before. It's interesting to me, even if it's not always within my value set, how other families deal with different kinds of problems. And so I think the point that I like to make here is that you have to think about your situation. And when you're struggling with how to help a loved one manage a disease, whatever that is, but in particular with a cognitive disorder, we really have to think about meeting them where they are. It's really a go-to sort of position that we want to help people in the way we think we would want to be treated or helped. And I think that a lot of the conversations I have with care partners and family is just trying to think back about this person and how did they deal with trials and tribulations in the past? How much did they want to talk about things? Are they a private person? How do they deal with disappointment? And trying to think back to that particular person's way of dealing with life in terms of how we're going to deal with that moving forward. In particular, an example I just want to highlight here is when it comes to personal care. There sometimes are couples who have really never been in the same room without clothes on. I mean, in terms of helping with personal care, there might be other reasons they were together, but if the bathroom door always needs to be shut, for example, and now suddenly you have to help them with their toileting needs. Imagine how that person is struggling with that, what they see as an invasive sort of action. So really, when we think about putting care plans together and we think about the advice we give to care partners and how to best help people, we always have to think about their history, their past, what kind of personality they have, but then trying to meet them where they are now and trying to brainstorm of how we can help that situation and help people feel better for themselves, but also for you, because we need you to feel comfortable in this relationship as well. So no one right way, but I think being kind and patient with yourself, and then trying to figure out, what are my loved ones' needs? How does this compare to where they used to be, and what can we do moving forward? So caregiving is going to look very different depending on the stage of dementia a person is in. Very likely when a person gets a diagnosis of a cognitive disorder, there could be a number of experiences. Some folks are going to be in absolute denial and say that is just not true. They might even start to avoid wanting to seek other medical care. Other times, people are grieving, they're sad. And I actually think that's a pretty healthy reaction, although a lot of care partners feel like we should do something about this. And can you give them a pill? And can you try to figure out how to make them feel better about this? Well, it's a devastating diagnosis. And so for a person to recognize that they are going to have this condition that will evolve over time, it is a normal response if they're struggling with either sadness or grief. However, we don't want folks to get stuck there, because as you can see on this slide, there are a number of phases that folks will go through. Some people with MCI, which is mild cognitive impairment, their disease may not actually even progress all that much. We're still learning more about this particular category. But what we know about most dementias is that they can take years and years to develop over time. And sometimes people will have a little dip, but then they'll sort of plateau for a bit. There could be a big decline if there's a major health issue, or depending on the sort of dementia that they have, that could just be a part of that. But in general, people will go through some sort of stage. If you look on the internet, sometimes it will say they're stage 1 through 7, or, you know, mild, moderate, late, or early, middle, late. But the point is to try to look at where they are, what kind of help they need, and trying to make sure we don't put too many interventions in too soon, because we really want to respect people's personhood, their independence, and connect them with resources and support. Folks that are early diagnosed can do very well with psychotherapy, for example, to learn other ways to try to cope with their condition, and do things they want to do while they're able to do them. The other thing to be mindful of is not only does caregiving look different for where you are in a process of cognitive decline, but what type of dementia. And unfortunately, we don't have time to go into a lot of the details of each of these. But when you have mild cognitive impairment, most people will not even notice. If you live with them and it's your spouse or your parent, you will very likely notice the differences and the changes that made you want to get a diagnosis altogether. But Alzheimer's is one of those things now we think people could be living with this as long as 20 years. So if you hear that diagnosis, we don't want to put the most maximum interventions in and think that this person suddenly needs 24-hour care and we have to take the car keys away. That is really going to be a conversation you have over time with professionals and support. And really what we want to do, I'll talk about later, but is try to have folks do as much as they can, as long as they can, until there are actual safety concerns. Frontal temporal dementia, and I'm just going to mention these quickly, is a condition we're just learning a lot more about, but it involves the frontal impulse sort of center of our brain. And people might do things like gamble or start to have behavior outbursts that they didn't have before, maybe start drinking more, but their memory might not be as impaired. And this is tricky for care partners because the person seems to be with it and, you know, we're not sure, are they just being difficult? You know, they used to act like this occasionally, but now it's worse. So the amount of interventions that a family member does for this particular condition is going to look different than a person who's early stage with Alzheimer's disease. Lewy body dementia is kind of similar. People might have symptoms such as paranoia or hiding things because they think people are coming in and moving things around. Again, memory change can vary, especially in the early stages. So it's really hard when you get this diagnosis to know how much help to do. And what to assist with. And this is where educating yourself as a care partner is going to be really important if you have one of these sort of unique, you know, less common sorts of dementia. This might also be true with Parkinson's. You know, with Parkinson's disease, people get that diagnosis early on, typically because the movement sort of disorder is more prevalent. And you might not notice any behavior or cognitive issues, but as the disease moves along, hallucinations or other sort of challenges might present themselves. And then vascular dementia is really a challenge because this might happen suddenly with a stroke or following a surgery. Sometimes people who have some sort of cancer could have a surgery, and the surgery itself could cause just some sort of change in the brain that becomes a permanent change. Sometimes it can improve a little, but when you're first seeing this person and they're changed and you're like worried, again, we start to assume that we need to put a lot of interventions in right away. And sometimes we just kind of need to wait and see. And that can be tricky because we don't also want to be too minimal in what we want to do, but we don't want to overburden our loved ones with care that's too intrusive early on in a process that might not require that much assistance. I want to take a minute just because of the work that I do in the hospital and mention two terms that if you're living with someone with a cognitive impairment, I would encourage you to get familiar with these two things. The first one is delirium, and these are acute changes. And so why this is important is because care providers feel like their world turns upside down overnight if either of these becomes present. With delirium, by definition, it should be temporary. And it's usually a change in mental status because a person has some sort of infection. And this is why I'm always encouraging everyone I work with, if that's super early in the stage or late in the stage, it doesn't matter. If you notice a sudden change in a person's confusion level or aggression level or irritability, or they are suddenly up all night or suddenly sleeping all day, make sure there's nothing medical going on, because it could be that there is, and this is like the clue to you to get some attention for that. The other one is showing up more and more and more in literature, and because it's such a long phrase to write out, they're just writing BPSD. And what that means is behavioral and psychological symptoms of dementia. And for some dementias, frontal temporal and Lewy body in particular, these are more common with the disease. The challenge for caregivers, and it's an unfortunate reality, is that caregivers will call the doctor or come to the emergency room and really hope that there's a pill that will fix this. And sadly, there really isn't. Antipsychotics, antidepressants, the benzodiazepines like Xanax and Ativan. For folks with dementias, especially certain types of dementias, those medicines not only cause great side effects and increased risk of falls and those sort of things, but sometimes they actually make the symptoms worse. So it's really important, if you notice these acute sudden changes, that you have a doctor that you can talk with quickly. Whether that's your primary care doctor, whether that's a geriatrician or a psychiatrist, people in the support groups that can give you some ability to redirect conversations. But it's really important to be prepared before these things occur, and just be familiar with what some of the options are. So this is a slide that I can't go through all together in any detail. This whole presentation for me, I could do this in 2 full days and just really give you all kinds of information. But providing the right amount of help at the right time is always sort of the dilemma that people have, because again, we talked about protecting your loved one's autonomy and letting them do as much as they can, but we also want them to be safe, and we want them to get what they need. But so that first box, and again, you'll have these slides, but it says allow for as much independence in those early stages as possible. If they can do it, if you don't use it, you lose it. So we want people to practice the skills that they can as long as it's safe. So cooking and even driving in those early stages, talk with your provider, but more often than not, until there are some significant visual spatial issues, especially in a familiar environment, in daylight hours, the diagnosis alone does not necessarily mean that you have to stop everything that you are doing. Might even involve still doing finances and stuff, but just know that you should maybe, as things progress, have a second pair of eyes looking at those. So trying to protect that, including your loved one in decisions and activities as long as possible. This is another thing that happens, I hear from people living with dementia prematurely. People feel like their family members think they can't do anything. And so we really have to include them in conversations, and try to have their input. If the time comes where that's not working out, then maybe we can pull back a little, but don't make the assumption that people can't participate in conversations prematurely. We really try to encourage people to look for that. Learning ways to redirect behaviors instead of direct confrontation. And I'll talk more about why we need to take care of ourselves as caregivers and work on our rest and our patience, because it's pretty common if you have somebody that's asking you the same question 10 or 15 times over 2 or 3 hours, or even the same hour, that care providers just get exhausted. It's hard to hear the same thing. It's hard to be patient all the time. It's hard to be calm all the time, especially if you're not getting sleep and rest and what you need. But the reality is that is what is going to happen. And so being prepared, finding ways to get some respite. I know a couple who spend a lot of time together, but the partner makes sure they just watch a movie together for 2 hours at night. And that just gives them the time to still be together, but it's reducing the amount of interactions that she needs to have with that particular person. So again, just trying to be creative in keeping yourself calm and recognizing when you're starting to reach the limit where you might be more snappy. Making sure the senses are up to date. Hearing aids, eyeglasses. We don't know if it's the chicken or the egg yet with this hearing thing. It's probably both. But if you're not hearing things, it's certainly going to make it more difficult. There can be wax in ears, battery issues with hearing aids. So for family members, especially who haven't had those devices, just recognizing that always those are at their optimal working level when possible. Knowing how and when to involve respite services, I'm going to talk more about that later. And this is a big one for couples, especially who've been married 30, 40, 50 years. It's really challenging to separate out what feels like this is just the way my husband is, or this is just the way my wife has always been, and she's just making things difficult for me, or she's just being argumentative. There can be a part of that because people are who they are. But as dementia progresses, people really do lose the capacity to intentionally make other people's lives difficult. And so this is where counseling is so valuable to the care partner, or just having an outlet where they can gripe and, complain about that person, but really when they're with their loved one, trying to figure out how to just be present and not assume that they are intentionally trying to be difficult. So that is important to sort through. That becomes our issue, that the healthier care provider sometimes. So we have to watch for that. The next two are kind of similar in that a lot of family members will definitely try to age in place. A lot of older adults prefer that. You have to really be thoughtful about, is your home able to accommodate that over time? Because if a placement or move is required down the road, the earlier in the dementia process, actually the better, so that people can get used to that new environment. But a lot of family members promise that would never happen. I will never, ever, ever do that to you. Or family members who are living with dementia will say, make sure you never, ever, ever have me go to a facility. And then the spouse says, okay. The challenge is, as I mentioned, our medical field, we can keep people alive. We can do tremendous things medically that we couldn't do 30, 40, 50 years ago. So people are living longer with very complicated medical situations. And that alone is often a barrier for folks to be able to care for their loved ones in the home forever. But the guilt, and if I had $1, if I had a penny for every conversation I have had in the last 27 years for trying to help ease the guilt that loved ones have when the time comes that they just can't do 24/7 at home, it's really painful. And so I think being mindful of that and really trying, just in case, I'm encouraging folks often to tour facilities just in case, so that there is that opportunity, so you don't wait for the crisis to then suddenly have to get information from a social worker about what you should do. So I really like to tell people that this is an important thing to really be thoughtful about if you can ahead of time. Unfortunately, these places cost money. Getting help in costs money. And so I really tell care providers, even in the very early stages, when you don't think you need to worry about that for a long time, meet with a financial advisor or an elder care attorney. You know, a lot of people feel like I can't afford it. Well, the time may come where you can't afford not to do something. So at least know what those limits are, be familiar with the Area Agency on Aging services, talk to a social worker or your minister, you know, just talk to somebody before a crisis happens. It can be stressful to think about, but it's also really important to be proactive with these sort of issues. So now I want to talk about you, the care providers, and what you need to do. And you're going to say, Leslie, I've heard this a million times. I'm doing what I can, but I just don't have time for any of this. And we're going to get to that later too. But what caregivers really do need to think about, if nothing else, Dr. Ragland and Dr. House's presentation last week was really on point for the recognizing how much sleep and exercise or movement, doesn't need to be, you know, lifting 50-pound weights, but movement for the care providers is very important. And if you can't sleep, and for the age group of people over 60, I think they said between 7 and 9 hours, and we all know at this point what good sleep is for us. But unbroken sleep is imperative to being able to keep calm, to keep your patients, to be able to keep up with the needs of somebody depending on you 24/7. So those things are really valuable. And if this is a area in your life you're struggling with now, I really encourage you to think about how can you manage this better. Nutrition and hydration, taking care of your own medical issues is super important. Often care providers will limit their own appointments because they have to make sure their loved one gets what they need, or they just have to, maybe they can't take their loved one out of the home, and so you know, they don't have respite, so they can't go to the appointments. But this is something that, again, I will tell you, working in the hospital, when folks suddenly have a crisis that could have been prevented had they gone to an appointment or seen the specialist that they were referred to, that's going to help hopefully prevent the crisis that eventually becomes a game changer in your life. So finding ways to do these things. Finding a way to recharge your own battery. You know, you hear the bucket thing, how full is your bucket? And if you are a care provider, chances are you have a bucket with a bunch of holes in it and the water's going out all the time. If you can't find ways to put more energy into that bucket, it's eventually your bucket's going to run out, and there is going to be a consequence, unfortunately. So figuring out how you're going to refill that bucket. Is that just having respite? Is it getting enough sleep? Is it being able to go to church if that's important to you? Is that going to a movie once in a while, or the art museum if that's something that is valuable to you? So just thinking about, in general, how to refill that bucket. Finding someone you can talk to. You know, I talked about the stigma, but I hope you recognized in that first slide that so many people are impacted by this illness of cognitive disorders, and they can look very different in very different stages, but recognize you're not alone. A lot of people they're either experiencing it now or they experienced it before. Just like that quote we started off with, people go through hard times. They always have, and they always will. So understanding that you can find other people somewhere in your network that can be helpful. And if you don't have it because you've outlived a lot of your supporters, or you just don't want to burden people, or they live too far away, this is where support groups can be sometimes super useful, or connecting with a good social worker who can try to find somebody that you can be connected to. And then that spiritual and social enrichment, whatever that is for you, finding ways, just to try to make sense of what is happening. So a lot of care partners tell me, there's just not enough time, or they don't know what to do. And so this slide is what interferes with care partners getting the help they need. And I'm preaching to the choir here, right? You all know this already because you're living it and dealing with this all the time. Very often, though, people just don't know what to do. And this is where, if you're here, you are in a wonderful little top niche of people who are really proactive, very likely, in trying to get information. So we want to keep spreading the word. We want to keep educating people. We want to tell people that help is available. But when it comes to the disease process, and this can be scary, knowing what that process might look like. And for cognitive disorders, just like our other health issues, every person is going to sort of progress at their own rate. But despite that, it's going to be really important to educate yourself and to try to be prepared if you can. Not enough time. That is, the thing I probably hear a lot about, that there's the book that is really prevalent is the 36-hour day, that talks about living with folks with cognitive disorders. And I think that's such a great title, because you feel like you have 36 or even 48 hours of things you need to do in this day. And somehow you're supposed to sleep and take care of yourself and exercise, right? So it seems completely unreasonable. But we really do over time need to find someone that can help us figure out how to prioritize or how to get that respite in, whatever that looks like, so that we can somehow find a way to get support to educate ourselves. A lot of caregivers feel burnt out. Again, this isn't an uncommon experience, and we can understand why people would get to that point, but we also want to try to encourage people to find the supports to prevent that, at least prevent the continuing feeling of burnt out, or the real severe feelings of burnt out, because that's even when sometimes elder abuse or neglect can take place, not intentionally, but over time, people just get to the point that they're so exhausted that they do things they would not normally do. It feels like another task on an already long to-do list, right? People feel like, I can't even think about a support group because I don't have time to go to the bathroom myself right now. So again, it's about trying to figure out your own life and resources and how to make that happen. Some people feel like groups won't work. And I'm going to say that I don't think support groups are for everyone. I don't. I think there are people who, for whatever reason, just don't find those environments helpful. However, I think there is another way of looking at these. Sometimes the value of support groups can be that you get other ideas of how other folks are doing things. Support groups can also be valuable in that people share resources sometimes, or ideas of what they've done or who they've contacted to get certain amount of help. But some support groups are not just about talking about your experience. Some of them are more didactic and educational. And these can be really helpful. Sometimes there's even caregiver series, like through the Alzheimer's Association, the Savvy Caregiver. Here, I think at Turner, we try to come up with some groupings occasionally that sort of are almost like a caregiver class. So pay attention to those kind of things, and don't just assume, that all groups are the same and that, there won't be any value to that. We really encourage people to think about that. Different ways to use those. No respite care available to leave loved ones at home. More day programs are starting to look at providing respite opportunities outside of the day program. So think about contacting some of those. And then the resources to hire or arrange help. I think that this is a very valid concern for folks. Thinking about contacting your area agency on aging or the elder care attorneys I talked about. If you have been, this is another one, I have heard a lot of adult children who say, my parents won't get help because they want to leave us this huge inheritance. I think a lot of adult children, at least in my conversations with many, many, many through the years, would prefer that their parents have the care that they need. And sometimes there's even with an elder care attorney, some things you can do, like putting part of that money into a trust or some sort of setting, but using some of that for themselves. So don't assume that your kids are sitting back and waiting for that. And even if that's what your parents did, it's a very interesting sort of way of a house as an asset that people don't always utilize, even to stay there and hire help in. That's another way to use that, but a lot of folks are concerned about that. But if you really are struggling with basic income issues, the Area Agency on Aging, or talking to a social worker about finding what resources are available through the state is a really important thing to do. Again, early on, don't wait for the crisis. Don't wait till you need it. Know what you need to do ahead of time. Okay, I'm going to try to speed up the last few a little bit about game changers, because I want Jim to have a lot of time. Jim, I'm probably going to need about 5 more minutes just to let you know. But things that are game changers, and this is where you really, this is a big clue to folks that we got to figure out a plan here. When your loved one starts to have more incontinence, falls, when sleep, when they're up at night and asleep during the day, this reversal, safety issues. If something happens to you and you need to take care of some health issues, these are opportunities to start to think about getting more help, or to think about whether home is really the long-term plan that's going to work for you. So when these things happen, it's super important to start to mobilize a plan with somebody who knows what's out there. In particular, I think hospital stays are real game changers for people. Sometimes even something as simple as a pneumonia, if a person with dementia comes in and they start to get more confused, that delirium I was talking about, and we, are a different group of people providing care, and we may or may not give them the same meds they were getting, hospital stays can really change the trajectory of your path in your loved one's journey. So treating any hospital stay or significant illness as a crisis is really important from my perspective. And this is 27 years of experience. It can go really well, or it can go really poorly and not go well after that. So recognizing getting help and trying to be proactive and trying to keep your loved one as capable as they can be is going to be real important. We recognize that more and more caregivers are actually diagnosed with depression, like a significant amount of mood disorder. It makes sense, just like the person who's receiving the illness, that when you find out your loved one has a cognitive disorder, you're depressed, you're sad, you're anxious, you're worried about what you're going to do. But there could be a need to getting professional help with that, and not really, minimizing that or giving into the stigma that it somehow means that we're weak, or we're doing something wrong if we just can't cope with this. Cognitive disorders impact the whole family, and it's going to impact all of you. And in order to be able to get through it well, you really need to be at your best mental health if you can be. So the thing I just want to say here is that men in particular are less likely to reach for help. And so if you have someone in your life that is a care provider, or you're someone a neighbor, a family member, encourage them to get an assessment, whether that's with their primary care doctor or a social worker, a psychologist, just somebody that can help provide support. We don't want to miss an opportunity to get people the help they need to try to feel better. Okay, and the last slide here I just want to go over quickly is that sort of a summary of things I've already talked about, but getting the support you need through the process, and that's going to look different in the spectrum of how the disease progresses. But getting the medical and emotional support, having a plan ahead of time for the progression, because sadly, dementia is progressive and it will get worse. And so how are you going to handle that through the different stages? If you don't have a plan, I will tell you that a crisis at some point, unfortunately, will very likely happen. And it's very hard to mobilize a plan at that point when you're juggling so many other things. So trying to have things done like power of attorney paperwork, so that you have that ability to help make formal decisions and legal decisions if your person becomes incapacitated. Think about support groups. And my last thing is, and again, I know you've heard this, but it is true. If you are not taking care of yourself, at some point it will be really hard to take care of another person. So trying to find the support to help do that. The last slide here before I pass on to Jim is a list of references. Some of these are things like the Caregiver organization that is a very good resource for care partners. There's CDC information. But some in particular, I would encourage you to look at is the Alzheimer's disease, the Alzheimer's Association, which is alz.org. The Lewy Body Dementia Organization is good for, even if you have an Alzheimer's diagnosis, they have a really good reference site for people that have behavior issues. And then the Parkinson's website. So lots of great resources here. And then my contact information was on the second slide in this packet. So if you have other questions, feel free to email me and I'll do my best to help you. I think I'm going to be available for questions later, but Jim, I'm going to pass on to you. So I'm going to stop sharing my screen. Thank you all for listening.
Thank you, Les. Excuse me. Good morning, everyone. Let me tell you a story. The older man was telling the group about his years of dementia caregiving for his wife, bedridden at home. As I listened to what he'd gone through and continued to go through, he may have heard my jaw drop. He turned to me, a first timer in the Dementia Caregivers support group, and he said, "You will be amazed at all that you can do and how well you can do it." He was right, but it took me years to recognize that. Years of a difficult, unwelcome journey, but also a journey of increasing love. For 14 years now, I have been care partner for my wife. She has Alzheimer's disease. In the early years, I was clueless. I didn't know what to do, how to deal with whatever was happening to her. I didn't know what help was available, where to get it, how to get it. These days, I have some knowledge, more confidence, and a lot of help. But I know I could have given my Kathleen so much better help if I had been better informed, better prepared when her disease first started showing up. Now, as with most dementias, there was not a specific day when I can say it began, but perhaps it was the day when she asked me how her sister was. Now, Kathleen's sister had passed away a year previous. So the question caught me off guard. And in those days, I didn't know any better than to tell her the truth. So I just blurted out, "Sweetheart, your sister is dead." And then I made it worse with, "Don't you remember?" With my ignorant insensitivity, I had made her weep. And then I did the same thing repeatedly when she asked me the same question over and over for weeks. When Kathleen then told me confidently, nevertheless, that her sister and her two boys were living in our basement, I knew there was something serious going on, but I had no idea what it was. Okay, there's 153 people on this call, and I know some of you are thinking, she was broadcasting classic warning signs of Alzheimer's. Why didn't this dumb guy recognize them? Because this dumb guy knew nothing about the disease. Instead of a disease named after the German physician Alois Alzheimer, I more often heard and understood it as old timers, with the sense that forgetfulness was synonymous with getting old and was usually the stuff of jokes like, "The nice thing about old timers is that you get to meet new people every day." I knew that Kathleen's anguishing forgetfulness was no laughing matter. But I also knew that it wasn't Alzheimer's. She was too young. She was only 57. Oh, yeah, okay. I just heard someone out there say younger onset Alzheimer's. At the time, I had never heard of that, much less that about 1 in 20 persons with Alzheimer's is under 65. Well, you didn't know very much, did you? You say. Hey, I come from a medical family, and I've spent 40 years working as a biological scientist. And you're right. I had essentially no knowledge about Alzheimer's or any of the many other diseases that cause dementia. I have since learned that my initial ignorance was typical. Most caregivers I've talked to over the last 14 years knew nothing at the start about the disease, much less how to be an effective caregiver. Now, some of that is because no one yet has some really key factual information like how to prevent it or cure it. But caregivers are uninformed in large part because they don't know what information exists or where to get it. Well, why don't they just go to the doctor and get all the information they need? You ask. Let me illustrate why that is not so easy. Get out, go away, my wife shouted at me some years ago. You're accusing me of being senile. I want a divorce. Without planning or preparing, I had just suggested one evening, perhaps we should go see a doctor about her memory difficulties. I was unprepared for her anger, her sense of shame, her fear of the stigma, and I spent that night in a hotel. First time in over 30 years of marriage that she'd thrown me out. Well, after a while, I got back into the house, but it was a long while before I could get her, even to our GP. And then it was with a bit of trickery. The doctor's office called, sweetheart. We need to go in for our annual wellness checks, or the insurance company won't renew our policy. In all of our years of marriage, I had never lied to her. Well, hardly ever. Well, my loving lie worked. We went to see our family physician, himself of retirement age. However, the things that were clear to me from living with Kathleen were not so clear to him in the 5 minutes that he spent with her. He should have, but he didn't even do a simple screening for memory or cognitive function. Perhaps he was of the outdated mindset that significant memory loss and thinking problems are just a normal part of aging, like gray or disappearing hair. I later learned that our GPs failing to take seriously warning signs like this are pretty common, especially among older physicians. In those early years, I was seeing Kathleen have clearly increasing problems, like getting lost, coming home from the gym she frequented for 20 years, being unable to put the groceries away, not remembering the concert that I knew she enjoyed going to the previous evening. Now, maybe Kathleen realized that something scary was going on, but she didn't admit it. Like so many others, maybe she had taken the plunge into the Egyptian river denial. Or perhaps there was truly damage in the brain, dying brain cells, broken connections, proteins gone bad, that prevented her from even being aware of her own condition. I later learned that's called, I think it's pronounced Anosynosia. Now, I knew something was wrong, but I thought it was something like depression or PTSD. And finally, Kathleen agreed to go with me to a counselor who soon advised me that I should take Kathleen to a memory clinic to check for things like Alzheimer's. In fact, the next 4 counselors that we tried all said the same thing, but I didn't push Kathleen, perhaps because it was easier for me to swim in the Egyptian river denial right alongside her. Over the next couple of years, my wife's difficulties got a lot worse. I sold the company. I retired early so I could take care of her. And my caregiving abilities got a little bit better through trial and lots of error. Eventually, Kathleen's resistance to getting medical help waned. She never explicitly accepted that she was having memory and thinking problems, but she finally agreed to see a neurologist. Well, it was a brief exam because midway through it, Kathleen stormed out of the clinic because of the insulting questions they'd asked her. Questions like, what city are we in? What year is it? Nevertheless, we got a diagnosis. Younger onset Alzheimer's disease, which I told the doctor I'd never heard of. We got a prescription for drugs that I later learned just compensate for some of the symptoms for a while. They're the equivalent of sinus decongestants that make you feel better while you still have the cold. We got an appointment to come back in 6 months. What we didn't get was any information about the disease or about caregiving or planning for future care. And I later learned in talking to many other caregivers that it's common for doctors to do the diagnostic dodge that we'd experienced from our GP, and that the dementia drop and dash, as we experienced at the clinic, is also a frequent move. Off the record, a physician told me later, there's such a stigma around dementia. Few doctors want to be the one who deliver the bad news. Well, of course, shunning the topic like that reinforces the stigma. So kudos to the medical professionals at the University of Michigan and in so many other places who do indeed level with patients and caregivers and follow the principles of a dignified diagnosis. I felt we'd gotten the brush off from that other clinic. Still, Kathleen's care got much better because I finally educated myself about Alzheimer's as a disease, not a disgrace. It's not a result of poor choices. It's not a matter of a person going bad as much as it is a matter of chemicals in the brain going bad. And once I started looking, I found a lot of information in the library and on the internet about Alzheimer's. And a lot of it was malarkey. Oh, there were guaranteed preventions and secret ingredient cures. Just send in your money. There was scientific sounding nonsense and quasi-mystical mumbo jumbo. Like an ocean full of salt water, the internet is full of material that's not fit to take in. So I didn't buy any Tibetan magnets or copper-infused crystals to cure my sweetheart. Instead, I just focused on reliable, evidence-based information, such as that from the Alzheimer's Association and its analogs in the UK, Canada, Australia, and our National Institutes of Health also proved to be a really good source of objective, fact-based, caregiver-oriented information. Now, living in Virginia at the time, I didn't yet know about lots of good information also available from the University of Michigan. And about 6 years ago, Kathleen and I followed our daughter when she moved to Michigan. I was taking care of Kathleen full-time by then, and I felt strongly that it was my job to take care of my wife, and I intended to do so on my own. Heck, I had read a couple of books by then. Well, yeah, once in a while I'd hire somebody to watch Kathleen while I went out to the dentist or something, but to my daughter's consternation, I insisted I could handle taking care of Kathleen's increasing needs, being with her 24/7, helping her shower, brush her teeth, dress, cut up her food, cleaning up soiled bedclothes and other messes. But all that was before the late night ambulance ride with Kathleen. On the way to the U of M, I realized I needed to change my approach to caring for my wife because I was the one on the gurney. Trying to get Kathleen settled into bed for the night, I had collapsed. The EMTs suspected I'd had a stroke, but we couldn't leave Kathleen alone, so we were both on the way to the hospital. It was a medical false alarm for me, but it was a real signal that my solo caregiving days were over. And not long after that, I committed the most awful act of love in our 40 years of marriage when I lied to Kathleen about a broken furnace and moved her to a warm room at the Memory Support Center. Even as I walked away weeping, I knew it was the right thing to do. It turned out that it was not only the right thing, but timely. When we made the move, the Memory Center staff discovered that Kathleen had a raging urinary tract infection, which I, in my overly confident caregiving mentality, had known nothing about. So within a few days, the Memory Center was inexplicably talking to me about the Department of Natural Resources, DNR, until I realized they were referring to do not resuscitate. Oh my. The staff's skill corrected for my ignorance, and they got the infection pretty well. They got the infection cleared up quite quickly. Now, all of that was over 4 years ago. And since then, we've had good times and bad. During the worst of the pandemic, for example, instead of being able to be with her about 7 or 8 hours every day, during the lockdown, I went 400 days between hugs. Oh, I was able to stay connected to her. Now, folks, I know about share screen and all that, but rather than flipping back and forth, let me just show you how we stayed connected through things like window visits and flowers and candy and baked goods and stuffed animals and several hundred greeting cards, and also a pillowcase with my picture on it and the inscription, "I will always love you." Her caregivers assured me that with that pillow, she slept with me every night. So the lockdown lifted, things got better. And this day, 4 years later, She is perennially cheerful in her new home. She is consistently happy to see me, but she doesn't know who I am. That's okay. Whoever she thinks I am, I just want her to know that I love her more every day and I will always keep her safe. These days, she has forgotten how to use a fork, how to walk, and nearly how to talk. But she has not forgotten how to smile at me and her caregivers. With her bright green eyes and an ear-to-ear smile, it's a little lopsided now after her latest stroke. And occasionally she'll whisper to me, "I love you," or to her caregiver. But Kathleen consistently lifts the spirit of everyone around her. One of the professional caregivers thanked me for letting Kathleen live there at the memory center. She inspires us, the staffer said. Of course, I miss Kathleen as she was, but I love her so much as she is. And she has inspired me in everything I have done since she moved to the memory center, with a little help from our daughter. See, back on the very first day after the move, my daughter knew that I was upset, and she consoled me with one glass of wine. And then she pretty much channeled her mother when she said, "Dad, just because you were a clueless caregiver for so many years is no reason you should let other husbands and wives follow that same path. So what are you going to do?" Oh, okay. I became a volunteer educator for the Alzheimer's Association. In the last 3 years, I have presented, 100 or 200 classes on the wide variety of topics that the Alzheimer's Association offers on the disease and on caregiving. But I always try to let my audiences know that I'm on the same journey, maybe a bit further along than they are. And I let them know that my sweetheart and every other person with dementia is and always will be exactly that, a person. It is so rewarding to see the light bulbs go on over people's heads when in a class I provide some information, some explanation, some insight that just lights up the face of a person in the audience. I can read in their eyes, "Oh, that's why Dad, that's why my mom is doing that." I'm happy to give information to people that I wish I had years ago. And as a volunteer, I do this not for the income, but for the outcome. More volunteers are always needed. Yeah, educating a handful or several dozen folks at a time, as I do, that's good. But it's not enough. With the help of folks like my pastor at Celine's Holy Faith Church a few years ago, along with some other pastors, librarians, and directors of senior centers, we have organized several multi-week presentation series. Here's one. This was a 12-week series. We've done 5-week series featuring not just objective information classes, but a variety of personal journey talks, such as presentations by persons who are themselves living with dementia, telling their own stories. We've publicized these series mostly by word of mouth and a few flyers, and we've had many hundreds of people come and learn and understand more about dementia, but that's not enough. We need to get much more information to the many caregivers and other family members who've had to start this dementia journey unprepared, unaware of what's going on, what to expect, what to do. And as the journey continues, caregivers still don't get the information that they need. I talked to a caregiver whose wife was already in memory care, but he didn't know that the reason some of the other residents in the memory center were in wheelchairs was because the disease destroys their ability to walk. I just thought they had arthritis or something, said this poor guy. Nobody had ever told him. Nobody had ever given him the information he should have had. But with about 5% of the US population dealing with dementia, either in themselves or as caregivers, and with those numbers going up, the need is great for medical professionals, for example, to provide much more better information and support throughout their patients' dementia journey. At the very least, medical practices could provide so much more useful information to persons who've just learned they have to deal with dementia. The NIH, I mentioned it before, for example, has a whole series of free, non-technical booklets on various aspects of dementia and caregiving. These are available in bulk quantities and they're free. The Alzheimer's Association also has lots of free, good caregiver information. But that's not enough. Persons with dementia are a part of, not apart from, our communities. Only a small fraction of persons living with dementia are sequestered at home or in a facility. The rest are trying to live their best lives in the community. And we need to help them do that. So a few years ago, a few friends and I set up a nonprofit called Dementia Friendly Saline. With the support of the city government, Saline's Holy Faith Church, EHM Senior Solutions, and others, we got our little town near Ann Arbor nationally recognized as a dementia-friendly community, one of only 2 in the state of Michigan. Our objective is to make it less difficult for persons dealing with dementia to live, shop, dine, worship, and participate in the life of the community. We work to more thoroughly inform the community, business owners, government officials, church and civic leaders, and ordinary people about the day-to-day challenges that dementia poses for their customers, members of their church or their club, their friends and their neighbors. We offer free, tailored workshops to any business, church, or other organization anywhere to show them the kinds of challenges that persons with dementia have and how easy it is to make things less difficult for them. So we now have a growing list of shops and banks and churches and other organizations that now display our dementia-friendly window clings. We added 5 more last month, and we've talked to our neighbors over in Dexter, Michigan, and we've also been asked by the city of Troy, Michigan, to come up and show them how to be dementia-friendly. And we've done Dementia Friends workshops for the Henry Ford Museum and for the Detroit Symphony. But that's not enough. With funding from the Ann Arbor Area Community Foundation and in collaboration with EHM Senior Solutions and several other senior care organizations, we offer monthly memory cafes. They are free, fun, informal social events for persons living with dementia and their caregivers and friends. The cafes feature musical performances, art projects, a drumming circle, seated yoga, exercise, storytelling, pie tasting, and all sorts of other engaging activities. It's an opportunity for persons on the journey to meet and compare notes with fellow travelers. There's free refreshments and equally free literature from sources such as the NIH and the Alzheimer's Association. We hold the cafe in the parish hall of Celine's Holy Faith Church, but with 5 microphones, 3 cameras, 2 speakers, and a giant TV, we offer it in an interactive hybrid format. Some in the room, some by Zoom. You can see some folks in the room and some folks on Zoom. At a recent cafe, we had folks join us on Zoom from Georgia, Iowa, and California. And the cafe we had the other day, a couple drove 2 hours in from Grand Rapids to join us in the room for the cafe. So wherever you are, hey, you're welcome to come to Celine's Holy Faith Church for the cafe. But wherever you are welcome to join our cafe. Contact me. I believe that my friend Shannon or Jennifer will magically make my email address appear in the chat or something like that. But feel free to contact me about the Memory Cafe, but it's not enough. With EHM Senior Solutions and others, we are currently working on setting up a unique program called Dementia Caregivers Companions, Friends for the Journey. It focuses on the caregiver with volunteer companions, offering the caregiver a strong shoulder to lean on, sympathetic ears to listen, reassuring hands, a calm voice of experience, and clear eyes for the road ahead. We would welcome any help we could get setting that program up. We know many caregivers out there could use a friend for the journey, but it's not enough. We hope to secure funding for a program we're calling the Dementia Day Spa. It'll be a periodic, day-long, fair-like event for persons with dementia and caregivers to shop, learn about care options, get a massage, have something to eat, listen to some music, see a movie, be entertained, and meet others on the journey. But that's not enough. We also want to build a robust and readily accessible and easily searchable library on all sorts of dementia caregiving topics. It's called the AIL, the Alzheimer's Information Support Library, electronic. From multiple reliable sources, we're collecting onto one site hundreds of documents, fact sheets, presentations, videos covering a wide variety of topics, aspects of caregiving. This is not intended for highly technical reports or data or for professional researchers. They've got other stuff, but this is for ordinary caregivers to give them a one-stop reliable resource so they don't have to wander around the internet to find reliable information on what they need to provide the best care for their loved one living with dementia. And okay, and there is so much more to do to make caregiving for a person with dementia less difficult. I know full well we can't yet prevent or cure dementia, but we can sure do a better job against ignorance and against stigma. But for now, I sincerely thank all of you for listening and letting me share my thoughts with you today. Thank you very much.
Thank you so much to you and to Les for sharing your expertise and experiences. That was really, really helpful hearing dementia caregiving from those very unique perspectives. So before we get into our Q&A, I do want to make a quick clarification that I mentioned that the next session would be Friday the 6th. It's actually May 3rd. So it's Tuesday, May 3rd from 10 to 11:30. And again, that's Coping and Resilience During the Pandemic, Voices from Aging Adults in the Nationwide COVID-19 COVID Study. So apologize for that oversight. We hope to see many of you there. So next, we're going to get into some Q&A. So if any of you have any additional questions, please feel free to put them in the Q&A box, and we will see how many we can get to in the next 30 minutes or so. So let's go ahead and get started. So some of these will be directed to one of you or possibly both of you, depending on the content of the question. So Jim, we're going to start with you. So someone asked, suppose you have a dear friend who has dementia. What do you tell him or her about the future quality of life?
I would encourage any person facing dementia to focus on living their best life. The good and the bad part of Alzheimer's and most of the other dementias is that they are slowly progressing, so that if a person is just now becoming aware that they have dementia, there are years ahead. And absolutely, please, do the things that Les said in terms of preparing, getting plans in order in terms of care and legal and financial. Okay, take care of that. But once that's done and all that stuff is in place, then focus on living the best life. And that means not giving up anything that you enjoy. Do what you enjoy, do what you want, for as long as you have the ability. As time goes on, some abilities will diminish, but your ability to enjoy life will not diminish nearly as quickly. The classic thing is do things like, travel. I have a good friend in my support group. She's only at the support group and her husband only occasionally, because they spend most of their time on road trips. They're having a great time. They're seeing the entire country. In the case of Kathleen and I, we went to see the Grand Canyon, classic sort of thing. And she had a blast. She'd been there before, but she didn't remember it. It's okay. She had a great time. So some of that classic type stuff, go ahead and enjoy as much as possible. As Les said, do the planning. Don't not do that. But then don't stop living. That's not a perfect answer, but it's the best I can do at the moment.
I think that's great advice. And kind of going back to what Les was saying earlier about mild cognitive impairment, that for some people, they may not see a decline at all or a very slight decline. And others, it's such an unpredictable journey that yes, I think it's important to encourage people to live in the moment and to enjoy life and do as many things as they can. So thank you. Okay. Yes, Les, please jump in.
I want to just add to that. I think it's typical and expected and healthy, as I mentioned, to deal with that initial shock of the illness and the diagnosis, and be a little sad if you need to for a little bit. Do not get stuck there. And it's really easy to do that and to get caught up in, I call it anticipatory anxiety of what's ahead, that we miss out on that ability to enjoy the moments that we still have. So doing that, and I'm going to just throw out there too, intimacy. A lot of couples will privately talk to me about that and think that somehow this diagnosis means that is forever gone. And again, it's one of those things of meeting your loved one where they are, doing all the things you want and enjoy doing to as long as both parties and all the family are, can do those things. Enjoy life and don't let this stop you. You don't know what tomorrow brings.
Thank you.
I'm cautious about oversharing, but I will reinforce Les's point that the onset of dementia does not necessarily mean the cessation of intimacy. Enough said.
Thank you. Yes, and this is slightly off topic, but I do want to mention it while I'm thinking of it. So Jim, thank you for sharing about the memory care cafes that you all do. I also just wanted to let people know that there are also cafes that are in Chelsea. And Silver Club memory programs, we just received word the other day that we received funding from the Community Foundation for Southeast Michigan to do memory care cafes in Ann Arbor as well. So there's lots of resources for that. And I think what's really nice about those is that it gives caregivers and the person with memory loss an opportunity to engage together in a way that is enjoyable for both. As both have mentioned, that there are many stresses of caregiving and not a lot of opportunities just to have fun and be silly together. So that's one way to do so. So just wanted to make that plug since we just found out about that. So moving on to the next question. So I think this could be answered by either of you, whoever wants to jump in. So the person asks, can those of us with mild cognitive impairment or mild memory loss empathize and advise others that also have mild dementia?
Go ahead, Les, if you want, but I have some thoughts on that.
Sure, I'll start, and then Jim, you clean up what I miss, okay? Yes, absolutely. You have a voice, you have an experience, and I encourage anyone who's willing to share as much as they're willing to share, spread the word about what your experience is, what just live your life and let people see that you can do that. I think the stigma that both Jim and I have talked about is prevalent. It's the reason that more people aren't honest and upfront about their experience. The reality is we've heard is that many more people are impacted than you probably realize. So chances are if you share that experience, you're going to learn that others also are managing this in some way. And I think it's also really healthy for people. I use the term, if you don't use it, you'll lose it. Practicing all the things that you're capable and able to do for as long as possible is we think even for some people might even be protective in some ways. So practicing, living your life, showing the world that people can live very well with dementia, sometimes for a very long time, because that's how we get past this. That's how we move forward as a society, that this diagnosis does not mean your life as you know it is over. The other group I'm going to mention, and then I'm going to let Jim talk more about that, but there's a group called Dementia Minds.
Yes.
That is really becoming more and more active with chapters around the country. And it's people living with dementia who are trying to do just what your question was about. Trying to get out there and be active. Jim, did you want to talk more about that?
Yes, indeed. Thank you for mentioning my friends at Dementia Minds. It's run by Brenda and Mark Roberts. They're out of Mount Pleasant. They are wonderful people. Mark is himself living with dementia, and he is a wonderful example of continuing to live not just a good family life, but a very active life. He's very much out there advocating for folks to live their best lives. He has a network of friends around the country. I also have some other friends. For example, in the memory cafe that I mentioned, one of the organizers of that memory cafe is himself living with mild cognitive impairment. The cafe we ran last 2 days ago, and in fact, my friend might be on the call, and if so, that's terrific. He not only organizes the cafe, but he was the master of ceremonies for the cafe the other day, and he did a musical feature, some old oldies but goodies and all that. And boy, he inspired everybody. He had everybody, singing. It was a wonderful event. Other people who know this gentleman in our church, I've mentioned, and they've said, "Oh, he's a great guy. We had no idea he had any difficulty." That's great. We don't want people with any form of dementia, but especially this condition called mild cognitive impairment. There's no reason people should feel any stigma, any sense of disgrace, or any embarrassment. It's a disease, it's a condition, and I celebrate my several friends who are doing things. They are continuing to live with dementia, so that's what we say about them. They're living with it. They're not just gonna die of it. Okay, enough said on that. Yeah, go ahead.
Great points, Jim. The other thing I want to comment on this question, though, is I was hearing this and talking myself and having met all kinds of people who cope with this all in their own way. Not everyone will feel like they want to share that or go to those groups. So for caregivers who think, oh, I have to get my spouse or my partner involved in this, tell them that it exists, but hear them and their comfort level on whether or not they actually feel like they want to do that. I personally, from just, I think my own anecdotal experience is that people who do get engaged probably, for some of them might do a little better in terms of how they cope with it because they are getting more support. But if your loved one hasn't been the kind of person who shares a lot before this diagnosis, chances are they aren't going to suddenly be a person who benefits from that a whole lot. So just be mindful of that. But if they're open to it, at least tell them about it and see if they might be interested.
Completely agree with that, Les.
Thank you. Yes, and I think, Les, like what you said earlier with caregiver support groups, I think is the same for some of these programs for mild memory loss as well, is that there's not a one size fits all, or each group is going to be slightly different, and that there may be one program that is not a good fit, but there is another that is. We are very fortunate that there are a lot of resources in Washtenaw County for different groups. The Alzheimer's Association has many groups. Silver Club, we have 2 mild memory loss social programs, Elderberry, which is for all women. We also have MindWorks, which is a mixed gender educational support kind of program. So there's a lot of options out there for people to try different things if one program they try and that's not a good fit for them. So next question. So what is the suggestion of how to respond to someone with early dementia who gets angry or distrustful when your opinion about something at hand is at odds with what that person thinks? So I think it related to, I just think of Jim, not, arguing with the person and, seeing things from their reality. So if either of you would like to expand on that a little bit.
Yeah, the short answer is go with the flow. Recognize that to a first approximation, things like being argumentative, it's the disease. It's not the person. Now, I'm not contradicting myself. I'm adamant about saying that a person with dementia is a person, always. But their actions, the things they say, the things they do, are caused by these problematic things are caused by the disease. Physical damage in the brain. This is not something that, oh, they're in a bad mood today and they just need to learn to be nicer. No, it's a physical damage in the brain. They cannot do any better. They can't remember that they just asked you that question, and they can't completely control their emotion. And Shannon just touched on something that is really, really important. Not necessarily very, very early on in Alzheimer's, but often later on in that dementia, but often early in some of the other dementias, a person has severely different concept of reality. They're living in a different world. It's because of the disease, the damage in the brain. It's because of problems with visual perception. The brain isn't processing visual signals correctly. Problems with memory about what just happened. Problems with distinguishing TV from reality. All this stuff. So it is really important for a caregiver to realize that if the person is doing something weird, something odd, even something problematic, try to recognize that they are living in a different reality. You can't join them. You can't really join. All you can do is respect the fact that they're living in a different reality. It took me a long time to realize, it took me a long time to learn this. When my wife would enjoy looking out the window and watching the bunch of little kids playing for hours and hours in the garden. Eventually, I learned not to tell her there were no kids in the garden. She enjoyed that hallucination. They were real to her. They were harmless. They weren't scaring her. So eventually, I couldn't see the kids, but I didn't tell them they weren't there. Les.
Yeah, it's really, you kind of set this up nicely. I can add a little bit to it. I hinted at this earlier in my portion, is that sometimes, particularly in marriages, some of those comments or patterns of communication feel familiar and feel intentional.
Yes.
This is how we've always argued, or yeah, he always does this, or she, always nitpicks, or whatever sort of put in your example. But what's different is well, first off, recognizing that pattern might be there. There could be a small amount of truth to a particular communication style. Just when you're married to someone for decades, those develop over time. But the biggest difference is that they really do not have the capacity to recognize what they're doing in the same way they did 30 years ago. And they really, really can't reset the process to talk to you the way you want them to. And that's what's really important when you're finding your blood pressure rising, or you're like, yeah, but, and you see yourself doing that, that's a huge clue to you to pause, stop, recognize that this is now your issue and not theirs. You are probably not going to be able to convince them that you're right on this one. You're probably not going to be able to get them to say, oh, I'm sorry, I didn't see it that way. Whereas maybe 20 years ago, you could get to that point in a conversation. So I think really recognizing what Jim is saying is that now you have a biological process going on in the brain with chemicals or just degeneration that's literally happening. And then another thing that happens with dementia is anxiety. Over time, people are fearful. They might not be able to articulate it, but there is desperation that starts to happen, that people can't get the right words. They can't get the right emotion out. They can't get the right sort of feeling, or they can't make you do what they want from you too, right? It's two ways. And once that happens, it's harder. We all get anxious sometimes, but when people have dementia, their anxiety is at a whole nother realm that we cannot really manage. Some folks are prescribing meds. Our experience is that they don't necessarily help. So the first way we handle this anxiety is to try to prevent it from happening in the first place, if we can. So that's, again, calm environments, patient care partnering, for, calm, chaos-free environments, routine. So it's really about prevention. But if we're in those situations and it's starting to escalate and you sense it's escalating, this is where care partners need to educate themselves that that is not a battle worth fighting. And in fact, we're going to maybe even make it worse for not only that person, but we're just going to bang our head against the wall that many more times and not get the result we want. So over time, educating yourself and really trying to just recognize what's going on. They can't help it, especially as the disease moves along. They really can't.
Among caregivers in our support groups, we typically remind each other, you cannot win an argument with a person with dementia. It can't be done. So don't try.
And I really like, Jim, thank you for pointing out, just going with the flow, and if their experience is not literally harming anything, then just go with it. Try to redirect conversations if you feel like it's escalating to that point, but really trying to figure out what's worth sort of confronting. And you'll find over time that most of it really isn't.
Right.
And if you're finding things are bothering you, that's a really good point to yourself to get more support for yourself, be social with your friends, stay active in your own things, and trying to figure out how to get the respite so that you can recharge, so you have that capacity to recognize what's going on and not go there.
Thank you both. Good points made. I have a little bit of a spin-off question of what I asked previously. So this question asked specifically about, someone who refuses to acknowledge that they are experiencing memory loss. Thoughts on that?
Like my wife, to this day, she never, as I said, she reluctantly agreed to go to the neurologist, but then she stormed out of the exam. She has never acknowledged that she has any difficulty, and of course now she's in late stage. Again, it is not. I know other good people disagree with me on this, but my feeling is that if the person is aware, help them and acknowledge and celebrate their life. But if they're refusing to acknowledge, don't force them. What's important is that they will be taken care of. That's our job as caregivers. As long as somebody will provide the care and the love that they need, they don't have to grapple with it if they choose not to. As long as they will be well taken care of. Make sure that you get the message to them that no matter what, you'll be safe. You'll never be alone. We'll keep you, we'll take care of you. We'll keep you safe. And beyond that, if they never know that they have Alzheimer's, frontotemporal, Lewy body, Parkinson, it's okay as long as they're cared for. Now that's Jim's opinion. I know other good people disagree with that. And I respect other people's opinion on that.
Oops, I clicked on something, so I'm not sure if you can see me.
Yeah, we're good.
Yeah, so I agree with Jim, actually. And I think this continues to evolve over time as we talk about it more and as more people are diagnosed and there are more groups and there's more opportunities. And I do think the stigma is coming down a bit, not where it should be. But I think, again, it really fits in with meeting people where they are and what they need and whose need is it for them to know. If it's helping them deal with their existence better by putting whatever other excuse in, and that's helping them feel a little bit more comfortable and feel better, then to me, that's a kind, helpful, just healthy way of helping them live with something that is difficult. I meet with a lot of people who go through a lot of trauma in their life and who have had really challenging experiences. And some people do that really well, and they do that because they're open about it. Other people get through things by not embracing it and finding ways to deal with it, by maybe not acknowledging it. And then again, the challenge with dementia is because of that brain degeneration. No matter how many times we try to say the sky is blue, if their perception is that it is another color, we just will very unlikely win that. So again, using our energy to focus on the things we can change, how we can positively influence, how we can, focus on reframing their reality, in another way. But I feel like that's actually fairly common, especially with some of the frontal temporal and the Lewy body dementias. And those folks, again, as I mentioned, tend to have a pretty good memory at the beginning of those diagnoses. So they really don't believe you. And by continuing to try to prove to them that there's something wrong, that you might actually make their symptoms worse. So the trick is, how do you partner with them for care? And in these situations, you really want to use that term, I'm their care partner. And you really want to just try to find creative ways to make sure they're safe and they get the help they need.
Great, thank you so much. Next question. So Les, you mentioned earlier the importance of respite. So this person brought up the point that this country is going through a crisis with care staff, not having enough home health care agencies or providers. Can you speak to those challenges and what kind of game plan there may be in order to get the type of care that people need?
Oh, I wish I had better words here. It's just a great time for those of you who have had any experience with dementia to write your legislators, both sides of the aisle, to explain your experience and the challenges. I don't know what the solution is. It was really tricky when I first started in social work. I have to watch the time. 27 years ago, we could get through the area agency on aging, we could get up to 24-hour care, but it was very typical to get 40 hours of in-home health for families who had a working partner. So whether that was adult child or a spouse, to me, that is the reasonable minimum that we should be able to get for people, because that allows people to age in place and for their loved ones to work and take care of themselves. That has chipped away, and it's impossible to get any help for people. But that minimum now is usually in our county in southeastern Michigan, not usually more than 20 hours a week, and that's for the most severe cases. There's a few outliers through the My Choice waiver program, but in general, we can't get help. So that's one part of it is the care. If you're fortunate to have resources, you can hire agency staff. Right now, the going rate in southeastern Michigan is $32 an hour. It used to be, before the pandemic, it was about $23 an hour. So it's gone up significantly. And that's because they can't retain direct care staff. But this is a problem in our healthcare system in general. This is a problem in memory care facilities, assisted livings, nursing homes, hospitals, healthcare agencies. And so I've never, ever seen it. And I have spent a lot of time in hospitals, pre-pandemic, post, during, and I do think it's a crisis, but I think writing your legislators to just let them know your experience. And I hope folks that do the budgeting and help with the agencies, especially for folks that don't have the resources to find private caregivers, they're the most impacted. Yeah, I wish I could say a more optimistic answer.
Yeah, another thought from a slightly different angle. I certainly agree with Les on what she was saying. But don't overlook lesser types of respite. Respite is so important. Yeah, excuse me. If you can get someone to come in and be with your person while you go out and have a day to yourself, that's great. But short of that, don't overlook lesser opportunities. When I'm talking about things like when your loved one is safely ensconced in front of the TV or taking a nap or something like that, do something for yourself, not just clean the house, but learn a language, pick up a hobby or pursue the hobby that you haven't been able to pursue, do something, even if it's for an hour a day. There's 36 hours in the day, right? Les told us about that. This is valuable. It doesn't sound like very much, but for example, I didn't bring anybody into the house to take care of Kathleen. I was there with her, but there were times when she was, happy to watch TV or napping, and I did what I enjoy doing. I wrote a book. It got published earlier this year. That just illustrates that, okay, there are other, make use of every angle that you can to get respite, to take care of yourself, caregiver, because you cannot be of any value to your loved one if you're 6 feet under. Take care of yourself.
Yeah, those are great suggestions, Jim. And I think, that's where sometimes working with a therapist about time management, it seems like it's overwhelming, but sometimes when you have a neutral person to do it with or to talk about these things with, that's where we see the value in counseling or support groups or even a good friend. Just sometimes other people help us see things a little bit differently, but using the time that we do have a little bit differently or maximizing on those opportunities where, again, TV, nap time, and again, engaging our families and our friends. Don't feel like we're burdening them with these requests. Very often they want to help, they don't know how.
Yeah.
So coming them with a very specific request is really reasonable. In fact, they might really, really appreciate that you asked.
Yep.
And I'd just like to add, for those who are not aware, adult day programs are also an option for respite. So Silver Club, we have a program for moderate memory loss, and there are other programs in the area here on Valley Pace. EHM Senior Solutions is going to be reopening their adult day within the coming months. So that's a social opportunity for the people with memory loss and respite for caregivers as well. So that's another option for those that may not be aware of that. So we're getting short on time here. I do have one more question that I'd like to ask, if each of you could briefly talk about. So someone had the question about, is it important or crucial in caregiving to have a routine?
Oh yeah. Go ahead, Les. But I would say absolutely. If things are disrupted, it makes it much more difficult. It's more upsetting. You have to be prepared to go with the flow. Things happen, but yeah, to the extent that you can have a fairly regular schedule, it keeps things smooth on an even keel for everybody in the household.
Yeah, I couldn't agree more. I think in Beth Spencer's talk about moving, she talks a little bit about transitions and some of the challenges that people have, but transitions happen all the time. So, not just from moving to a house, out to somewhere else. The other thing about that too is predictable meal and sleep patterns. In particular, I think are really useful. And if you have a loved one who's struggling with the idea of respite care, of bringing in an outside person, for example, I really do encourage you to do that as sooner rather than later, if you can, in really teensy weensy increments. Someone just stopping by and staying for 10 or 15 minutes even, because that transition, that pattern change can be escalating if suddenly you have been the one who's been providing 24/7 care. And now, Susie Smith comes and spends 8 hours with your loved one and they don't know who this is and they're not sure why they're here. And so patterns, routines are important, but when you start to make changes, doing that very thoughtfully. I also want to talk about naps just really, really quickly, because if your loved one is starting to take naps during the day, it might impact their sleep at night. So really be cautious about not too many naps, cat naps if they're required, but really trying to keep on top of that sleep pattern if you can, because once those sleep cycles reverse, that might be your new day. So watch those patterns.
Wonderful. Thank you both so much. That was a fantastic presentation. I'm sure people learned a lot and found that very helpful. So for those of you who want to rewatch or share with a friend, this recording is going to be available on our YouTube playlist with all the other Healthy Aging series. So if you haven't bookmarked it yet, it's a good time to do so. So that way you can refer back to those programs. And thank you again, and we hope to see you all soon.
Thank you so much for having us. Best
Bye.
wishes out there.